Okay, this is the normal appearance of thyroid gland. You have a follicle which contains the colloid, and you have the follicular cells, and you have parafollicular cells, which are very, very important. This is a smooth, rounded, gross appearance of what a follicular adenoma surgical specimen basically looks like. Now, this is another example of a follicular adenoma on a histopathological examination. More or less like a normal thyroid gland architecture, it basically maintains. Now, some of these adenomas, they start overproducing the thyroxine. Then they are called toxic adenomas. If you take any given case of thyrotoxicosis, doctor, what is the most common cause of thyrotoxicosis? Graves. But 5% of thyrotoxicosis are because of a toxic adenoma which is not grave, which is not Graves' disease, is what you have to basically appreciate. Female to male ratio will be around 9:1, and around 54% of the follicular adenomas present like a nodule, 37% present with thyrotoxicosis, and 95% of the toxic adenomas are basically benign. Once more, is what you have to basically appreciate. If it is a thyrotoxicosis due to Graves, what is a characteristic feature? Eye signs. Without eye signs, you can't call it as Graves. But thyrotoxicosis due to toxic adenoma doesn't occur with eye signs, is what you need to appreciate. A toxic adenoma presents like a hot nodule on the scintigraphy. And how do you basically treat it, doctor? It is the thyroid lobectomy by which you will be able to treat it. And if you do that, then you need to give post-operatively thyroxine until the, see, when one part of the thyroid gland became nodular and became toxic adenoma, that will lead to suppression of the remaining part of the gland. So if you remove that, thinking that I have only done lobectomy, other lobe is there, no. Why to give thyroid supplementation? No. You have to give thyroid supplementation even though you have done lobectomy in a case of a toxic adenoma, because a long-standing toxic adenoma will suppress the entire other part of the gland. That's the point to appreciate. Now let us talk about the malignant thyroid tumors. Differentiated tumors, papillary, follicular, they are all differentiated, 80%. Once more, just like toxic follicular adenoma, female ratio is more even for the thyroid carcinoma. And usually it presents like a solitary thyroid nodule in the middle age. Always that's the reason it's a challenge whenever somebody has a solitary thyroid nodule, especially so when they are middle-aged. Our main worry is whether it is a thyroid carcinoma, is what you have to basically remember. Then one more important dictum. If it is a man in the middle age or if it is a child, any nodule is more likely to be malignant. If it is a female with a nodule, less likely to be malignant. That's a very important dictum. Now let us talk about papillary. 50% of this papillary carcinomas of thyroid are less than 2 centimeters in diameter at the time of the clinical presentation. Tumors which are less than 1 centimeter in diameter, what is the name given for that? Them? They are called micropapillary lesions. You may say, oh, such a simple fact, does it need a mention? Yes, sir. Less than how many centimeters you call micropapillary becomes a bottleneck MCQ in the exam. Less than 1 centimeter is what you are going to remember. Two features, two histological features that characterize the papillary carcinoma. Samoma bodies, orphan ani-eyed cells are the two important features which you need to basically remember. So this is a typical example of a papillary thyroid carcinoma on cut section is what you are able to typically see, doctor. This is that calcified sphere, which is also called samoma body, is one of the important features, samoma body. And these cells are there, no doctor, these are called orphan ani-eyed cells, which have a ground glass nuclei, is a very important feature. One more example of a samoma body and how a papillary carcinoma typically with the orphan ani-eyed ground glass nucleated cells typically look like. Now, one important thing about papillary is half of the papillary are multicentric. Bhagwan idhar bhi hai, udhar bhi hai, har jagah hai. If you only try to identify one area and say that this is only papillary, no. There is a papillary in the contralateral lobe, there is a papillary focus, multicentric is a characteristic feature of the papillary. Papillary is known to go to the regional lymph nodes very early. And that is the reason whenever you find a thyroid tissue aberrantly in any of the lymph nodes, unless proven otherwise, it is considered to be papillary carcinoma. Another favorite question of the examiner. Lateral aberrant thyroid, what is it histologically? It is a papillary thyroid carcinoma histologically whenever you find it ectopically. So, if you do only lobectomy, suppose if it is a small lesion less than 1 centimeter in size, that is adequate. This is in contrast to our earlier enunciation. What is that? Papillary are multicentric. But still if the size is less than 1 centimeter, studies have shown that lobectomy is more than enough. You don't need to be aggressive. But otherwise, if it is not a micro lesion less than 1 centimeter, total thyroidectomy is considered to be the surgery of choice. Most of these tumors are basically TSH dependent. What does it mean? Suppose you have done lobectomy or thyroidectomy. What happens to the patient? He becomes hypothyroid, obviously. Hypothyroidism stimulates TSH production, and the TSH comes and stimulates the growth of even a little pinch of remnant tissue is there, it will make it grow. How to avoid it? After doing the total thyroidectomy, give thyroxine supplementation to the patient in sufficient doses, not insufficient. In a sufficient dose that it lead to TSH from not rising. Don't let patient go into hypothyroid state post-operatively. Give him thyroid replacement so sufficiently that TSH doesn't rise. Because if it rises, then even a little pinch of tissue left over after doing total thyroidectomy or lobectomy, from that once more papillary carcinoma recurrences will occur. This is the point you need to finally appreciate. So giving a good amount of dosage of post-operative thyroxine reduces the recurrence and improves the survival is a very important rule. And about 80% of the regional lymph nodes in papillary carcinoma, because it runs quickly to the lymph nodes, no, they typically show microscopic involvement. Then if that is the case, just like breast cancer, axillary lymph node gets a breast cancer running and coming to it. Is there any role for, along with thyroidectomy, to also to do a regional lymphadenectomy or not is a very important issue. Lot of studies, they are not showing clarity. Some study says it is good, some study says no difference, some study says it's useless. So it is still unclear. But one thing is clear. Those guys who had a lymphadenectomy along with thyroidectomy, their survival, if you follow them up for about 5 years or 10 years, is no way different from the people who did not undergo the regional lymph node dissection along with thyroidectomy, is what you have to basically appreciate. So that is the reason ultimately what is the via media solution, a typical word used in real estate deals. Ultimately, what is the compromise solution? Whenever you do thyroidectomy, try to also do sampling of those lymph nodes. If there is no evidence of any nodal metastasis, you don't need to do anything. And if there is any nodal metastasis, then you need to post the patient for modified neck dissection to remove those regional lymph nodes. That is the present ultimate protocol. Now, few comments on follicular tumors. Basically, FNAC cannot differentiate adenoma from carcinoma, follicular. So that is the reason, what is a very important treatment that you will be doing if FNAC shows follicular cytology? You do lobectomy. Lobectomy also acts like an excision biopsy, and do a frozen section, histological examination. Suppose if the frozen section confirms that there is a capsular invasion, that means it is carcinoma. Then there is a role for total thyroidectomy. Suppose if the frozen section, when you do lobectomy, is not showing any capsular invasion, then it is adenoma. There is no further surgery which is required. And if you do total thyroidectomy, what is the one more advantage? If total thyroidectomy is done, doctor, if you give I-123 radionuclide scan, the only tissue capable in our body to take up a I-123 is thyroid. You are saying that you have done total thyroidectomy. Still, if that I-123 is being picked up, means there should be some metastasis. So total thyroidectomy will also allow you to identify the metastasis when you do the I-123 scanning during the follow-up, is what you have to basically appreciate. And post-operatively, what do you want to do? You have to give thyroxine therapy. Sufficiently enough that it does not lead to any TSH increase. And don't let the patient go into hypothyroidism. Same principle, just like papillary. So this is an example of a follicular thyroid carcinoma which we are talking about. That light tanning appearance with small foci of hemorrhage is one important feature. See, this is a follicular adenoma, doctor. This is the capsule. Is the capsule invaded? No. When you have done the lobectomy, capsule is not invaded, it is intact. This is all the follicles and this is the capsule. Whereas in this case, typically this is the capsular part into which the follicular cells have invaded. So the invasion of the capsule is an indication of follicular carcinoma, is what we are parroting about. This is another example of a follicular malignancy where the follicular cells are invading into the capsule and capsule got breached because of the invasion of the follicles. This is another example of a FNAC which is showing the presence of follicular cytology, which makes you to go for lobectomy and check the frozen section for any capsular invasion. So summarize, doctor, the favorite question of the examiner. Papillary versus follicular differences. Multifocal unencapsulated. Lymphatic spread and metastasis to regional nodes characterize the papillary. Solitary encapsulated with hematogenous spread and metastasis to the lung, bone and brain characterizes the follicular carcinoma, is what need to be remembered. Ultimately, how will you follow up a case of thyroid carcinoma? Every year I-123 scanning patient need to undergo to detect whether there is any recurrence, though the patient is asymptomatic. And suppose if recurrence is there, If you treat it, then that becomes curative. So treat the recurrences is the rule. And in order to, then one more important thing. Serum thyroglobulin has a great role during the follow-up. If there is any recurrence, serum thyroglobulin characteristically increases. That's the reason it has more of a follow-up value rather than a diagnostic value, thyroglobulin. And now comes a very important discussion. In case of a differentiated carcinoma, lobectomy versus total thyroidectomy. So what are those arguments which are favoring the total thyroidectomy, doctor? Why you want to do total thyroidectomy in case of a differentiated carcinoma? That is either papillary or follicular. Thyroidectomy is needed because papillary being multifocal. Argument number one. Total thyroidectomy will reduce the risk of local recurrence. That is, to the regional lymph nodes there can be recurrence. Then if you do total thyroidectomy, you can be able to, that will also helps in any ablation which you can do with radioiodine. Radioiodine ablation is facilitated if you happen to do the total thyroidectomy. Suppose in case of any recurrences are there. Then after total thyroidectomy, you can depend on serum thyroglobulin to detect for the presence of any recurrence. And if he is a regular surgeon, then the morbidity is low. Regular surgeon, if he is there, he knows that what to injure, what to not injure. But what favors lobectomy? Only lobectomy. Many of these patients, lobectomy, they do not require radioiodine. And there was a fear. If you do lobectomy and remove if the remaining lobe is remained, this differentiated carcinoma, can it progress into a undifferentiated carcinoma and lead to a poor prognosis? Lot of studies have been done to refute that assumption that there will be no undifferentiated carcinoma in the leftover lobe even if you do lobectomy. So there is a reason lobectomy is still favored. Then those who propagate the idea of total thyroidectomy argue that multifocality mandates what you call total thyroidectomy, but it is still controversial. There is no definitive study which has proven that because of the micro-foci in the contralateral lobe, do we really need to do total thyroidectomy, or lobectomy also is equally good, is still uncertain. And there is no study to prove that total thyroidectomy undergone patients will have a better prognosis than lobectomy patients. And if you take hypoparathyroidism as a risk, it's more with total thyroidectomy but not with lobectomy. So that is another thing that favors the lobectomy. So you must know the arguments in favor of these two common available options, surgical options for the management of a differentiated thyroid carcinoma. Now, aplastic carcinoma. Less than 5% of thyroid malignancies are all basically anaplastic. A very good point Fahima is proposing. Thyroglobulin is only for medullary, na? No sir. If you do total thyroidectomy, post-operatively when you are following up, thyroglobulin is of a use even for the differentiated carcinomas including follicular and papillary. Because thyroglobulin is normally produced by the thyroid gland. So after removing also, if it is still continue to be produced, means unless there is a recurrence of a tumor tissue, it is not the sole property of medullary carcinoma. Good point Fahima had raised onto the floor. Now doctor, If you look at the thyroidectomy for anaplastic carcinoma, it is not at all feasible. And one important caveat which you need to remember is avoid incision biopsy in case of anaplastic carcinoma. If you do incision biopsy, then there is a chance of spreading the anaplastic carcinoma. Radiotherapy and chemotherapy are the two main modes of management, not the surgery. Radio and chemo. In the case of the anaplastic carcinoma, which is more common in elderly people, which is very, very aggressive in nature. And if you detect anaplastic carcinoma, means 6 months you are packing the luggage in journey to heaven. So survival is only 6 months. So this is how the surrounding tissues of the mediastinum get infiltrated by the thyroid anaplastic carcinoma. The typical appearance of a undifferentiated tumor in the form of anaplastic carcinoma is what need to be remembered. Then one to comments on thyroid lymphoma. 2% of thyroid malignancies are lymphomas. In what kind of backdrop do they arise, doctor? Hashimoto's thyroiditis or a non-Hodgkin's B-cell lymphoma. Typically, thyroid lymphoma will be arising. And how does it basically present? It can present sometimes like a goiter along with generalized lymphoma, can be the presenting feature of thyroid lymphoma. FNAC can be able to make you identify that lymphomatous morphology. Now comes the favorite MCQ of examiner. What is the treatment of choice of thyroid lymphoma? Not the surgery, not the chemotherapy, but radiotherapy is considered to be the treatment of choice. And generally prognosis is good. That's a good thing about thyroid lymphoma. Now comes the medullary carcinoma of the thyroid. But proportion of carcinomas which are medullary are only 8%. It basically arises from the parafollicular C cells. 1/5 of medullary carcinomas are familial. 1/5 only. 1 in 5. It is the autosomal dominant inheritance with a complete penetrance is the most common form of inheritance. And what syndromes are associated with familial? FMTC. MEN2A, MEN2B. In both the scenarios, medullary carcinoma of thyroid can be there. But 80% of cases of the medullary carcinoma of thyroid are basically sporadic in nature, is what need to be remembered. If it is familial, it is more likely to be bilateral, but sporadic is more likely to be unilateral, is what I want to underscore to all of you. So doc, MEN2B, MEN2A and FMTC are the three important forms of familial medullary thyroid carcinoma. In medullary thyroid carcinoma, 50% will have lymph nodes at presentation. If it is a familial form of MTC, then they are more likely to be multifocal and bilateral, is what need to be remembered. So with regard to medullary thyroid carcinoma, both the things are possible. 50% by the time of detection only, lymph nodes are involved. Even through blood also they can spread. And they can involve bone, liver and lung. And what did they produce? Medullary carcinoma of thyroid? Calcitonin they produce. I think Fahima got confused between thyroglobulin and calcitonin, I believe. Calcitonin is what they basically produce. MTCs. And they also produce carcinoembryonic antigen also. And what is the treatment, doctor? Total thyroidectomy in case of medullary thyroid carcinoma. And you can depend on calcitonin in case of medullary thyroid carcinoma in order to follow up for the presence of any metastatic disease, is what you have to basically remember. So this is a medullary thyroid carcinoma which is showing a solid pattern of growth. It does not have any connective tissue capsule, just like papillary. Only follicular has a capsule, right? So that's important to be appreciated. Then there's a typical immunohistochemical staining which is using anti-calcitonin antibody stain. to detect the presence of medullary thyroid carcinoma. There is a amyloid stroma, which is a very classical feature in case of medullary carcinoma of the thyroid, and this is a typical congruent staining of that amyloid stroma in case of medullary carcinoma of thyroid is what you have to basically appreciate. Now, if you detect a familial case of the medullary thyroid carcinoma, doctor, then is there any role for in the other pedigree, other members of that pedigree, if they are also found to have the same abnormal gene of that familial medullary thyroid carcinoma, is there any role for the prophylactic total thyroidectomy? Just like in familial endometrious polyposis, what did we do? Prophylactic colectomy we have done. So similar to that. Yes, sir. Total thyroidectomy, I mean hereditary MTC may prophylactic total thyroidectomy is indicated. In case of sporadic medullary thyroid carcinoma, you will do total thyroidectomy. Whenever we do total thyroidectomy, what is the argument? Regional lymph nodes ko kya karna? What to do with them? Right? So, you need to also do central lymph node dissection plus or depending on modified radical neck dissection also you need to combine. So, that extensively, unless you attack MTC, it is known for a very bad outcome is what need to be remembered. So, ultimately what are the complications of the thyroidectomy, doctor? Hemorrhage, the wound, the sepsis, scarring, respiratory obstruction. Why respiratory obstruction can occur? Laryngeal mucosal edema can be there, clot can form underneath the strap muscles, and there can be recurrent laryngeal nerve palsies bilaterally. If you are a first year MS general surgery, you have operated first time in your life with a knife. So, you love to cut everything very extensively and patient ends up in respiratory obstruction. When bilateral recurrent laryngeal is gone, both vocal cords comes medially. They both will close the glottis. Hava andar nahi jayega, bahar nahi nikaleka. Then tracheomalacia. If it is anaplastic carcinoma, what will happen? Anaplastic carcinoma, it will basically lead to tracheal compression, and that compressed trachea is very weak trachea. And the trachea can undergo collapse. Or even if it is any other, basically anaplastic carcinoma, you won't do surgery, thyroidectomy. But if you take other forms of thyroid carcinoma, if they cause a tracheal compression for long time, it becomes weakened. The moment you do thyroidectomy, it will collapse, leading to development of respiratory obstruction post-operatively. Then you may end up in doing a nerve damage, which is a very important problem. Recurrent laryngeal nerve palsy can occur. Suppose if it is an incomplete injury, then cord moves to the midline. If it is a complete injury, then cord all the way will move to the cadaveric position, almost close to the midline. So that's the main issue. That's the reason you must know whether you operated and injured the patient's laryngeal nerve, or the pre-operatively only whether thyroid carcinoma due to its invasion has led to laryngeal nerve palsy. In medico-legal cases, that becomes an issue. If patient loves to sing post-operatively, he is unable to sing, he will make you sing throughout your life. So that's the reason you need to basically do pre-operative cord inspection, and your ENT surgeon must certify. Because about 3% of patients can have asymptomatic recurrent laryngeal nerve palsy. Post-operatively, if you discover recurrent laryngeal nerve palsy, it may not be due to you. He may be carrying it. 3% of cases asymptomatically they can carry. Then, if parathyroid is injured, hypocalcemia can occur, pneumothorax, air embolism, etc., etc. And post-operative hypothyroidism is an issue. So ultimately, what are the clinical pearls that we are going to remember for the MD exam? So this is a very important table, doctor, which is a summary of what all we said. Radiation is a risk factor. Childhood may don't unnecessarily subject a baby to too many radiology procedures unnecessarily. Little common cold also you do a chest X-ray because because the mom is a pediatrician or a dad is a pediatrician. Bro, if you are a pediatrician altogether, you must manage the baby without doing investigation. Then any congenital dysharmonogenesis or any iodine deficiency is a predisposing factor for follicular carcinoma. Then multiple endocrine neoplasias are the predisposing for medullary. And earlier if you diagnose any well differentiated carcinoma like papillary or follicular, it may de-differentiate and convert into anaplastic. And iodine deficiency also can predispose to anaplastic. Then doctor, most common form of thyroid carcinoma, what is your answer? Papillary. In pediatric patients also, suddenly examiner may ask a funny question in exam. Most common pediatric thyroid malignancy. Suddenly you don't start thinking adults may, since it is papillary, it can't be in child. Even in child also 75% of cases are basically papillary thyroid carcinoma is what need to be remembered. Youngest to get thyroid carcinomas are all papillary, 30 to 40. Oldest to get are all basically anaplastic. If you take the sex ratio, doctor, more female tendency is typically found in case of follicular, 3:1. Then as it is 2:1 in the case of the papillary. Then how does papillary present? Painless mass, dysphagia, dyspnea, hoarseness, and generally a euthyroid state. This is important. Euthyroid is papillary. Then as if you take medullary, it can present with a palpable lymph node, which is a very special feature of medullary. And how do you diagnose? FNAC can straight give you a diagnosis in papillary, but you need basically lobectomy in order to make out follicular cancer is what need to be appreciated. Then calcitonin can be a very important indicator of medullary. Medullary is also recognized because of the presence of the amyloid is what need to be understood. Then coming to the gross features, we have seen areas of necrosis, cystic changes, and only partially encapsulated is papillary, but completely encapsulated and solitary lesion is follicular. Multifocality is the nature of papillary. I leave to you anyway. Whether I read or you read, you have to read. My idea is basically to present you this table, which is a summary of what already we have discussed. So you need to review all these important features. Now, few more clinical pearls for the MD exam. If you look at the solitary nodule, majority of the heart nodules are benign. Heart nodules are benign. It does not mean that all cold nodules are malignant. Around 5% of cold nodules are malignant. Majority of the heart nodules are basically benign. If only 5% of cold nodules are malignant, we can also say majority of the cold nodules are also benign, no? Yeah, that's right. Now, but one thing is there. Yeah, okay. Now, how about thyroid ultrasound? Why do we use it in evaluation of thyroid carcinoma? Whether the lesion is solid or cystic. To assess the nodule size and to identify any impalpable nodules within the thyroid, ultrasound will help you. Why is it important to know whether it is solid or a cystic nodule? If it is a solid nodule in thyroid, it is more likely to be malignant than that of a cystic nodule in thyroid is what you need to remember. In case of medullary carcinoma of the thyroid suspected, or if there is any family history of the medullary carcinoma of thyroid, then how do you evaluate? You need to basically give calcium pentagastrin infusion and look for the production of the serum calcitonin levels. So a rise of the serum calcitonin is a very important marker of medullary carcinoma of the thyroid, and don't forget calcium pentagastrin infusion test in case of medullary carcinoma. In fact, with a calcium pentagastrin test, if the calcitonin levels are elevated, you don't need to even do FNAC. It is as good as FNAC. Straight away you can go to thyroidectomy, regional lymph node dissection and modified radical neck dissection. So that's what you can treat it as medullary carcinoma. Now how do you manage, suppose if FNAC is giving you confidence that it is a benign lesion, how do you want to manage? Just follow it up. It is known to regress by itself. If it grows, doubt your cytologist. Maybe that guy in his diploma pathology might have copied the answer sheet of somebody else and passed the exam. So if it grows, remove. If it remains the same, then repeat FNA. That is the management of a follicular adenoma which is benign, if the lesion is benign on cytology, on FNAC. That's what you need to remember. Then what are the few things on surgical management that you should not forget? Lobectomy. With lobectomy, most of the times you should get a Supreme Court judgment whether it is malignant or benign. If you are unclear about it, you have taken a frozen section waiting with the gloves, what is the outcome? You will be asking your pathologist. Sir, I am not able to decide whether this is this side or that side. Then as a surgeon, what you have to decide? Go back and complete it. Do the total thyroidectomy. If the lobectomy surgical specimen histology is not very clear. Then when will you do lobectomy plus isthmectomy also in which situation? If it is a papillary less than 1 centimeter, if it is benign unilateral lesion, then you will do lobectomy plus isthmectomy. When will you do total thyroidectomy followed by radioactive iodine? If it is papillary more than 1 centimeter, or if it is follicular or hertel or medullary, in all those scenarios, do total thyroidectomy and following that give radioactive iodine is considered with the management. Then what is the most important thing for you to give radioactive iodine? Can you do lobectomy and give radioactive iodine? You can't. If you are planning for a post-operative radioactive iodine, then you need to do total thyroidectomy regardless of whatever be the size. That is a very important principle. And there is no role for the radioactive iodine in case of undifferentiated carcinomas or even in medullary thyroid carcinoma. There is only role for that which is useful in the well differentiated carcinoma is what you have to basically understand. In which situation you want to do the central lymph node dissection, regional lymph nodes. Medullary is the only histology where you want to do central dissection prophylactically in addition to the total thyroidectomy. And also you need to add to that a modified radical neck dissection on the affected side. Because medullary carcinoma of thyroid, unless you are that aggressive, it turns out to be aggressive on the patient. And how will you follow up? After doing total thyroidectomy, it will help. You can depend on thyroglobulin to discover the presence of the recurrence. And you will be using radionuclide iodine uptake as a way to monitor for any microscopic recurrences after doing the thyroidectomy is a very important principle. Now, few comments on medullary thyroid carcinoma which we already had reviewed. Percentages are important in medullary carcinoma of thyroid. Men 1 it occurs and also it occurs in men 2. What percentages? 20% of those who have medullary carcinoma of the thyroid, they will have men 2. But those who have men 2, 100% of them will have medullary thyroid carcinoma. Agreed? That's important. Then, if medullary thyroid carcinoma is a part and parcel of a bigger plot called men 2, how is it different from the MTC which is due to FMTC or MTC because of men 1 or MTC which is sporadic? How is it different compared to men MTC which is part of men 2? If it is a part of men 2, it is more bilateral, comes in younger people. It will typically have a worse prognosis when MTC is a part of the men 2 is what need to be remembered. Then when it is a part of men 2, it will show red proto-oncogene mutations. Once more, on the top of the world, there is a men 2A, men 2B. So, if it is men 2B, if MTC is a part of men 2B, it is most aggressive out of all. Followed by when it is a part of men 2A, followed by when it is a part of FMTC. You are able to catch me up? So, if it is a MTC which is a part of men 2B, what is the dictum? Perform thyroidectomy. Perform thyroidectomy when the child is 6 months old. If you found men 2B chromosome. If it is men 2A, perform thyroidectomy by 5 years old. That is a very important dictum. Prophylactic thyroidectomy. There is a lot of role in case of medullary thyroid carcinoma. Then in case of no nail biting, that's very obsessive this thing. I end up without teaching, only watching the nail biting activity. So big lot of medical students, we have nail biting habit, right? Lot of our students. Some students have yawning habit. So we used to have 4 to 5 very, very yawning students about 4 or 5 years back. So when we start class, teacher also start yawning. So okay. Anyway, so okay. Now amyloid on pathology is a typical feature which we said in medullary thyroid carcinoma. Then increased serum calcitonin is another important feature. And will medullary thyroid carcinoma can be able to take up radioactive iodine? No sir. Why? Because it basically arises from parafollicular C cells whose habit is not uptake of radioactive iodine. So they do not concentrate iodine is what you have to basically remember. Then few pearls about anaplastic in addition to the basics which we already reviewed. The only surgery you can ever do is tracheostomy in anaplastic. No role for surgery at all, no role for total thyroidectomy. Then even for palliation also there is no role for resection in anaplastic. Basically you need to do medical management. Radioactive iodine ablation or thyroid hormone suppression is what you need to do. Then what are the situations where thyroglobulin can act as a marker to discover the presence of recurrence? Only 2 scenarios. The tumor is well differentiated, papillary or follicular. Patient has had total thyroidectomy, only after total thyroidectomy only thyroglobulin can act as a way to basically discover the recurrence. Then few comments on lymph nodes. If it is a papillary carcinoma or follicular carcinoma, is there any role for prophylactic lymph node dissection? No, sir. Only medullary thyroid carcinoma is the only form of carcinoma which is having a need of regional lymph node dissection. Then it is typically used if the lymph nodes are palpable, or when you have done FNAC of that lymph node, regional lymph node, it is showing the presence of the medullary carcinoma thyroid cells which are metastatic. Then only regional dissection is basically indicated. Regional lymph node dissection. So, the lymph nodes are divided in turn into level 1, level 2, level 3. Anyway, we will review it in the next surgery. But for now, remember, when do you call radical neck dissection? What will it take it away with it? What will it spare? Is one of the favorite question of the examiner. It takes away with it the jugular, level 1 to 6 lymph nodes plus cranial nerve 11. Then what is modified radical neck dissection? Sacrificing jugular and cranial nerve 11 is considered to be little barbaric. So they discovered modified radical dissection. In this you will take away the lymph nodes at the level of 2 to 7 and you will be sparing the internal jugular vein, sternocleidomastoid, the spinal accessory. These things are spared in case of modified radical neck dissection. But modified radical, when will you do, doctor? Medullary carcinoma of thyroid only, there is a role for radical neck dissection. Neck dissection is what you have to basically remember. So what decides the prognosis if it is a differentiated thyroid cancer? The age, the grade, the extent, the size and TNM. Obviously when so many things are there, 5 children are there, who is most favorite? Age, grade, size, most important. In fact, if I ask you, single greatest deciding factor of prognosis in papillary and follicular means age. Is the age more than 45 or age less than 14? They are the most important factors which basically decide the prognosis. Then we are continuously saying that there is a nerve injury possible in thyroidectomy. So once more to review that surgical anatomy, superior laryngeal nerve. Fundamentally they are all the branches ultimately of vagus. It is both sensory and motor. It has got an external branch which is basically motor to cricothyroid. So when it gets injured, what will happen, doctor? That high pitch tone and loss of the projection in the voice is the one which basically will suffer. And it is also sensory to the supraglottic area. Then how about recurrent laryngeal? Recurrent laryngeal innervates entire larynx except the cricothyroid. And any bilateral injury of that will typically lead to development of the respiratory obstruction is what you have to basically appreciate, doctor.